very warm welcome and a traditional Austrian service to our coverage from the ASCO annual meeting. This annual gathering of the American Society of Clinical Oncology is recognized as one of the most important events in the field of oncology in cancer medicine and took place from May 29th to June 2nd, 2026 in Chicago. My name is Claudia Altmann-Pospischek. I am from Austria and I have been living for 13 years with metastatic breast cancer. I am a patient advocate and I blog under Claudia's Cancer Challenge. On behalf of patients today, I am very pleased to be here today with the radiant German frontman of oncology, Professor Dr. Sherko Kümmel, whom we all know as Doc Kümmel from social media, to take a look at significant new studies. Dear Sherko, would you like to briefly introduce yourself?
So, dear Claudia, first of all, thank you very much for the invitation. Also to patients today, my name is Sherko Kümmel. I head the Breast Cancer Center at the Essen-Mitte Clinics as part of a large women's cancer center. So I am clearly working in oncology now, but I focus, that is to say, for about 20 years now, I have been dealing exclusively with all forms of therapy related to breast disease.
Yes, thank you very much, dear Sherko. We have taken a closer look at a few studies on metastatic breast cancer that are of particular relevance from a patient perspective and will now provide some insights and explanations. So I am happy to hand over to you, dear Sherko, and ask you for the slides.
So we have, and not just last week when we also saw each other at an event, I would say, to introduce the topic, when we talk about metastatic or advanced breast cancer, most people naturally never want anything to do with it, which is understandable. And secondly, everyone thinks, well, what's the point? That's a notion that maybe comes from the old days, but what we see, and you're a great example of this, is that today, when I start a therapy, and I'll give you this now, as an introduction before we talk about all the new therapies and possibilities, I can't predict what will come next. In the past, as I said, 20 years ago, people would say, well, maybe that'll help for 3 or 4 months. Could be. Then we had this option and that one. And after that, well, we'll have to see, because we didn't really want to say that we didn't have anything left. So today we start with therapies, and sometimes they work for years. And then we know that in the coming years, there will always be new therapies that will be added, which we don't even have available today. That means, so to speak, by now we repeatedly have a proportion of patients, and that number will increase, who benefit from these therapies for a long time. And these 10, 13 years are incredible in your case now, but more and more people will experience this. And currently, we are at the point where this is even possible for every 5th or 4th patient. And that was, I would say, not even remotely imaginable 20 years ago. And the development, it must be said again, where we stand today, it's not progressing step by step, but rather we have an exponential curve along which we are continuing to develop. So that's just a preliminary note, especially for all those listening to this, because understandably, they are in a very difficult situation. That's the disclaimer. Those are our disclosures. Advanced breast cancer. And this is the first study, which I will summarize for you. If you want, you can afterwards check the Kaplan-Meier curves in detail or look at the individual situations or the subgroups. I always try to summarize it a bit so you can ask yourself, what can I take away for myself? So the study is about triple-negative breast cancer, where we always have to do chemotherapy. And if it has recurred, that is, if metastases have occurred and we are faced with the question at the initial diagnosis, so the first diagnosis with metastases, what do we do in that situation? And there is the TROPION study with datopotamab deruxtecan, so strange names. We abbreviate them. We can't always pronounce them properly during presentations. So internationally, we just say DATO. That's easier for us in every situation. So here is a study that we have looked at, which said if we take our standard chemotherapy, which we have used up to now, and then compare it to DATO, the TROPION-02 study. So patients with metastatic triple-negative breast cancer for whom immunotherapy in addition to chemotherapy is not an option. First-line therapy. These are the patients who can be included in the study. We know this, we've already talked about it because the study was already presented last year, and we all expect that we will get approval for this in the not too distant future. The endpoints always include looking at progression-free survival. So for how long could you administer standard chemotherapy before the disease progressed further. So standard chemotherapy versus this so-called ADC, which we've discussed many times before, the antibody drug conjugate. How did it perform? And then what we looked at now in the overall situation was that we observed that the median overall survival was extended by more than 5 months. Now, everyone says, well, what are 5 months? When we talk about 5 months in oncology, we're still talking about first-line therapy. So choosing a medication for the first time, and then we're half a year better than what we had before. If I compare that to what we had just 3 or 4 years ago, we used to celebrate an improvement of 8 to 12 weeks when we saw that there was the next advancement. And now, in first-line treatment alone, we're introducing a new type of medication, the so-called ADCs, and just with that, we're already nearly half a year better off. That's the overall picture. That's how you can sum it up. These are the curves we always show. The upper curve is the new medication, that is datopotamab. The lower curve is our standard, which we've been using up to now in the overall situation. What was presented at the American Cancer Congress now was the PFS2. That means, and we have already seen the first part, where it beats standard therapy. But does that continue for the patient as the disease progresses? That means once I stop taking datopotamab, but instead, because there is progression, I take the next medications, does the effect that I achieved earlier through the improvement, does it last sustainably? That's what this PFS2 is. That's perhaps the simplest way to describe it. Again, translation here where you see the curves. When you look at the bottom, well, we're doing our patient academy to empower patients. What does this mean here? Hazard ratio 0.61, subtracting 0.61 from 1 equals 0.39. That means, in other words, 39% better. That's an easy way to translate it. You can read every study for yourself this way. By now, you are becoming empowered, so to speak, maybe sometimes even smarter than one or another doctor who might not be able to translate it quite as well yet. So this therapy alone is 39% better, even in the subsequent treatment cascade. That's essentially the crucial point. In the end, as I already told you, that's the summary. So my summary in this situation is that datopotamab should become another standard in first-line treatment of advanced triple-negative breast cancer who lack this specific immune expression. This means when we can't offer any more pembrolizumab therapy. I've added that, and since we lack approval but the study showed success, we're applying to health insurance companies, and I can share the first cases with you. Nearly all health insurance applications for this therapy at our center are approved, as insurers also recognize this is becoming a new standard.
Thank you very, very much. I find this very, very interesting. The data for datopotamab are really excellent with improved OS and PFS, an effective new drug for triple-negative disease. What was not part of the study here and what interests me greatly, so what are the primary potential side effects? Could you possibly give us a brief overview? What is relevant and to be expected for us as patients?
In comparison, we see that we can use datopotamab for a longer period than standard chemotherapy. This means that this new type of chemo is better tolerated. But that doesn't mean everything is perfect. We still have this fatigue issue and blood values can change. What we have to pay special attention to here without having to do prior checkups, but we specifically pay attention to the fact that eye irritation can occur. So I would say that we also take preventive measures early on. Here at the center, nowadays, since we often use these medications years earlier already as part of clinical trials, which is why I believe those who participate in studies live longer. As a result, we learn early because in the study protocols, monitoring is close and frequent, and there are detailed instructions on what to do in case of side effects, so we know exactly how to act. Now, when it comes to widespread use, that is when everyone is allowed to use it, you, as a patient, definitely need to be proactive yourself if you experience eye irritation. Let your oncologist know as early as possible so that countermeasures can be taken and something can be done about it. But now we also have to say, since we already have several years of experience, we see that it is not so severe in our daily routine. Unlike with other medications, we do not perform a prophylactic eye doctor check, which we used to have to do for other things. By now, we know that with eye drops, fluids, and so on, we can do very good prophylaxis. For us now, we can sum it up like this. It is a well, I would say, manageable and therefore an easy to handle substance.
Thank you very much. I'm pleased there's something new again, and we're moving straight to the next study.
So then we jump over there and then they say, yes, ASCO touched on this a bit, the blockbusters that came out last year at ESMO and in San Antonio, to say these are new, absolutely new standards of care, and to see what happened next with the patients. So again, PFS2, and this time with a different ADC. And now I'll explain ADC to you again. What is that actually? So on the one hand, it's the Trojan horse, meaning I have an antibody that attaches somewhere to the cancer cells, and in its backpack, I have a chemotherapy. This is called the payload, and the chemotherapy is attached with an adhesive to the antibody in this situation. In pharmaceutical terms, this is called the linker in this context. And nowadays, both the linker and the antibody are being modified by AI so that we achieve high effectiveness. What happens? So the antibody attaches to the cancer cell takes up this antibody complex, and the chemotherapy is in the backpack. That's why I always call it the Trojan horse. Inside, it is then dissolved by the lysosomes in the cell. You remember biology class, right? Your biology teacher was wrong, that it just attaches to the cell, then a lightning bolt comes, right? We all had those lightning bolts that were drawn for us in our notebooks. That is not correct. The cell takes it up, digests it, and because it has then absorbed the chemotherapy and further releases it, the cell is destroyed. At the same time, the chemotherapy is released again and can also attack the surrounding cells. And now this is the trick with the new approach. AI is used to modify the linker, the adhesive in the whole thing, so that when the ADC complex has attached to the cell via the antibody, then often the first backpack is already released or a portion of it, and in this way, it also takes along the surrounding cells. Why is this so important? Because of course, many people also ask, breast cancer is heterogeneous after all. Some cells have a lot of HER2, some cells have little, and so on. That means that's a brief explanation of why these new ADCs, antibody drug conjugates of this generation, are so successful overall. So now we come to sacituzumab, same study program, same population of women and patients in this situation, triple negative, no option for immunotherapy in this situation. Now let's take a look at it. It is almost identical in this situation. Endpoints, PFS, so practically almost identical studies, and so different ADC, same population. That's how you can sum it up. The results for PFS2, I'll show you here first the progression-free survival. It is also significantly better in this situation in the ASCENT study. And the time until the next therapy that was needed was also significantly better. Hazard ratio, again, 0.7. So 30%. Please don't make the mistake of saying that in the other study it was a hazard ratio of 0.61. So I'm somehow 8% better. That doesn't work. That's not scientifically valid at all. You can't compare the individual numerical values of studies against each other like that. That doesn't work. And it's also not, well, it doesn't hold up in the overall situation. Besides all that, of course, we also have the side effects. By now, we are already quite familiar with sacituzumab govitecan and can handle it very well. We've learned that we provide primary support for the white blood cells, GCSF, simply to counteract this neutropenia, to prevent it. We've learned how to manage diarrhea as well, and that we do a lot prophylactically in all of this. That means that we used to have to admit patients on sacituzumab to the hospital because of side effects more often, I would say, in the past, and today it's a rarity. So we're learning to handle it. To sum it up, we have the same situation again. Months of therapeutic benefit in all of this, and now I'm writing this here because when we put the slides together, sacituzumab govitecan is another standard in first-line treatment of advanced triple-negative breast cancer without so-called PD-L1 expression up until approval with a health insurance application and all of this. And now with that, let's go back to Claudia. We were working on the slides until late last night. And yesterday at 2 p.m., or maybe the day before at 2 p.m., the news came that sacituzumab is officially approved. So today, we can tell you with the very latest update available, we no longer need to submit a health insurance application if we need an ADC for patients in this treatment situation. So this news is 24 hours old. That's why I can tell you this, since we are very deeply involved with this topic. As soon as there is a vote at the EMA, we are informed about it immediately in that situation as leading centers. That means the knowledge is available to us on the very same day, especially since we are also represented in the committees. So that means positive messages, and now you have the very latest news. You can use sacituzumab. If anyone is facing this decision, or if someone in your circle of acquaintances is, now it's no longer necessary to apply to the health insurance company, you can just get it.
Great. Thank you very, very much. That's good news. We'll take that with us. We already know sacituzumab govitecan. I do as well from my own experience. May I ask you, how are your patients generally doing on SG?
I think what we need to do is prepare people a bit for the hair loss, which we have managed to get under control. That just has to be said.
That's a major topic for us patients.
Absolutely, yes. And that also needs to be weighed, especially in shared decision-making, which is something you have to do nowadays, especially when you have several ADCs available in this situation. It's not because the medication is particularly bad, but rather it's the half-life. That's simply one aspect. You have to inform patients about that. These two major other side effect complexes that I already mentioned, neutropenia among them, which can lead to treatment interruption, dose reduction, hospital stays, or diarrhea. By now, in highly trained teams, this is no longer an issue. As always, in medicine, prophylaxis leads to success. So I give many patients loperamide or Imodium prophylactically and tell them to take 2 tablets a week spaced out. And if they say, I'm almost constipated, I say, then just skip it. Yes, it's really not a problem in this situation. Always waiting for the symptom first, or trying to react only after the symptoms appear is, in my opinion, not exactly the most effective strategy in most cases.
And I can reassure you again from my side, diarrhea was never an issue for me. I had a bit of itching, a rash, but no diarrhea at all. It can be so different from person to person.
You can also consider this. There are studies with SAKK that involve prophylaxis against itching, for example, with Fenistil or without. The study results are inconsistent, but it doesn't really matter. Then I take 2 tablets. If you say itching is actually never my problem, I skip it. Or if the tablet makes you a bit tired, then you also skip it.
Yes, but that's really nice. You can respond to it. That's the good thing.
Exactly. You can always react as needed.
I think it's fantastic what has happened in recent years, especially for triple negative. And of course, a longer progression-free period until the next therapy is good for the soul. And you can breathe a little easier again, make plans and live, and that's the beautiful thing about it. Let's move on to the next study.
So let's keep going. We still have a lot ahead of us. We've prepared quite a bit, Claudia. So now pay attention. Now we're going into the situation. Same treatment path. Triple negative first-line treatment, but now the immune cells have been measured. This CPS score is positive, so it is greater than or equal to 10. That means immunotherapy can be used. So up to now, our standard has been chemotherapy plus pembrolizumab. So paclipembro, napaclipembro. Also gemcitabine, carboplatin, pembro, and so on. That was the question addressed by the next study, the next ASCENT study, ASCENT-04, as it was called, where they asked, okay, what about the patient group if I now take sacituzumab govitecan, that is SAKK, and combine it with pembro versus our conventional chemotherapy plus pembro? So that's basically what we knew. The first data on this also came out last year. Primary endpoints, again, were PFS. You already know all this. You are trained in it. That's nothing we need to focus on in all of this. And here, too, we looked at PFS, too. That means last year we saw that it is significantly better. ADC plus pembrolizumab versus conventional chemo. Now we looked at whether the effect lasts longer. These were the data. Here again, the first analyses. You can see that pembro was already a huge step forward. In the past, we only used chemo. Then we said pembro and chemo that is the lower red curve, meaning the standard. And that was already much better is now the lower curve. And if you now take the chemo and switch to a better chemo, the ADC, that is SAKK plus pembro, then you suddenly get so much better in the overall situation. And then one looked at it up to the next line, PFS2, and here you see, once again, highly significant. And what you see here, what happens here is that the curves stabilize. That's what I told you at the beginning. Here, all of a sudden, we have patients who stay on the therapies for a long time. Just take a look at that. In the past, we always saw the curves like this. I'll exaggerate it a bit to make it clear. And now, of course, we see that as well. But suddenly we are reaching plateau phases, and these plateau phases didn't exist before. And that's a huge success, so to speak, with these new medications. That's part of the immunotherapy that is having an impact, meaning making the tumors immunogenic, what we call hot, and also the new therapies that can, so to speak, be extended as a result. So here too, we see that we are again significant. Just look at the differences, 10 months versus 17 months. This change alone has a generally better tolerated therapy, and I would say over 8 months of improved survival for the patient. My summary for everyday clinical practice: when we use pembrolizumab, sacituzumab govitecan plus pembro should become another standard for patients where we measure these PD-L1 expressions. We do this for every patient and check whether there is expression or not. And today we already apply for it with the health insurance company because it is not yet approved for this situation. We only have the data showing that the effectiveness is higher with the combination.
Really fantastic. 17 versus 10, more than 7 months. That's truly an extremely significant result. Sherko, may I ask you, when do you think this will be reflected find their way into the guidelines? In our last talk, you explained so nicely that for you, the guidelines represent the minimum standard. When can we hope that it will also be written down there?
Well, we always have to distinguish between guidelines and therapy recommendations. That means, for example, with the AGO, we take the liberty and the right to evaluate only the scientific data. That means these are only therapy recommendations. There, we have already given this combination a positive evaluation, but we have to point out that it is not yet approved. So we all know how to handle pembrolizumab. We all know how to handle sacituzumab in all of this. But in order to get it for the patients without an application to the health insurance company, we basically still have to wait for approval.
Thanks a lot. Yes, indeed, and that usually works out quite well.
Yes, with the combination, it's sometimes even bumpier than we would like it to be. But if you were to ask me, will this really become a new standard? Yes, it will. That's the difference between guidelines and what we discussed last week. If I know and understand this data and then submit the health insurance application during my consultation, there are also many who perhaps don't even bother to do this or anything like that. That's also the difference that can be seen. And if the health insurance company agrees, then just this woman alone is already being treated so much better.
And the guideline, what do you think realistically, when will it actually be included?
By next year, it'll definitely be included in all guidelines globally.
Then let's move on to the next study.
So now we come to the question, and now we come to a name. Let's try it together. And by now, all my colleagues feel the same way. I'm always happy about that, even internationally. Iza-Bren, a real tongue twister, exactly. I always tell the industry, who comes up with these names in their situation anyway? Also, when it comes to, let's say, inventing names, and when it then comes to the pharmacies, I find the names still not really catchy. That means all of us have agreed internationally on one thing. We call this substance Iza-Bren. I say in the DACH region, so in German-speaking areas, when we give English presentations, it's called Iza-Bren. So that means when doctors talk about Iza-Bren or Iza-Bren, then that's essentially this substance. Now we have to clarify, can I get it by request or something else? I'll say that up front. No, this medication does not exist yet. This is just something we both looked up to show you. If, for example, you start a therapy with SAKK or something else, this medication will probably come your way at some point. Who knows, in 2 or 3 years, we will probably get an approval for this medication in all of this, but there is no approval yet. It is not available in the pharmacies yet. So now when we mentioned sacituzumab and datopotamab, this is, for example, a third or fourth generation of ADCs. And what I am about to present to you now from this present PancoBreast02 study is the next generation of ADCs. And that is exactly why the team has prepared it so well. It is the first bispecific antibody, meaning it has 2 anchors. I try to show it to you here. It targets EGFR, which is often overexpressed in cancer cells, as well as HER3. This is also common on cancer cells. You might only know HER2, but there's actually a whole HER family. We have HER1 through HER4, and it targets 2 of them. And with that, it is independent. And usually something is expressed. So that's the theory behind it. And everyone was very excited and said, well, if I now attack more targets, have the chemo in my backpack, and if I then also use AI to modify the linker, this adhesive, in such a way that I can target various cells in the area where I go, where I attach, so to speak, then it works. That's the story behind it. In the past, we always had a lot of stories, and very few of them were then positive. Today, as I said, most of the stories that come up actually end up being positive in studies in medicine. So what was done? Metastatic triple-negative breast cancer. And now, and this is important, so pay attention, after the therapies, which we normally know, then Iza-Bren was administered. So after an ADC, we can use another ADC or something else. But what usually comes next is just the classic chemotherapy, eribulin and capecitabine, various options. You see them here, eribulin, capecitabine, gemcitabine, or vinorelbine, for example, in this situation. And then, in contrast, the new ADC, which I explained to you earlier with 2 arms now, the Iza-Bren. So primary endpoints, again, PFS, and here they took a bold step, which is very important. They were so convinced that they said, we're going to have a combined endpoint. That means only if both are positive, the study is considered positive. And so they also included overall survival and PFS. So for us as medical scientists who are also very scientifically driven and look at this as a whole, statistically and qualitatively, this is a very high quality study. Now let's look at it, and I'll just let it sink in for you what that means. Now, you've gone down this path with me, what this hazard ratio means. Effect measure might not be the right name for this if we classically translate it. Hazard ratio 0.29, what does that mean? It means we have a 71% or 70% improvement compared to classical chemotherapy, and you can also see that in months. This is what we have typically achieved with standard chemo in later lines, on median. This is what we will achieve with the new medications. So, highly significant, and you can see what kind of results these are in this situation. That's why there's a bit of euphoria from me in this situation, and that's why my introductory words in this situation. Just keep that in mind. This is something that might be approved around the end of 2027 or maybe 2028 in the whole context or potentially in this situation. That means it will benefit you at some point in the future where now we aren't even thinking about it yet. And here you can already see that overall survival is 40% better already in this analysis. So, to put it in new terms, these are mega data. Yes, really good data. So, let's come to further endpoints. If you now say, I see this, these are the so-called waterfall plots. That means for us, we try to present a lot of data graphically to make it easier and quicker to grasp. Here, on the left side, you always see the patients who did not respond, meaning where the medication was not successful. On the right side, it was successful. Now you see with classic chemotherapy, it's about 50-50. And here you can see that almost everyone had a benefit. So, in a way, and that, of course, also reflects the response rate. ORA stands for overall response, meaning a response rate of 50% after so many chemotherapies. Such a response rate with chemotherapy is not normal. So, with what we have had in our arsenal up to now, we have not seen this ourselves. Side effects, Claudia is always keen to make sure we take a close look at this, and rightfully so. We need to examine this. Here, we have something a bit like classic chemotherapy, where we have to keep an eye on neutropenia a bit more closely. These are things we monitor, where there may be pauses, dose reductions, and so on, but I often call them paper toxicity. That means we see them on paper, but the patients don't actually feel them. Yes, things like diarrhea, stomach pain, and hair loss are symptoms that patients really feel overall. Yes, but they have very little of that here, essentially. So, to summarize my conclusion with this study, the first so-called bispecific ADC, Iza-Bren, has shown a major advantage and could soon be introduced as a new standard for triple-negative patients. Insurance applications, because of course the question always comes up, when is an insurance application possible? Once the medication is available in pharmacies after its first approval somewhere in the world, usually in America, we then start submitting insurance applications.
Great. What I'm taking away is mega data. That's what we want to hear. Of course, for us, it's also about the side effects. You already briefly mentioned neutropenia, leukocytopenia. To put it simply, bad blood. What can we do about that?
We can now consider GCSF prophylaxis throughout this entire process and copy that. We needed that up until now. We needed it with sacituzumab, and it is something that will certainly be implemented here again, and where we will learn quickly, especially with these, when we administer on day 1, 8, and so on. Just like with SAKK, it seems we will move ahead with this fairly quickly in our practice. We'll soon start the next studies here with Iza-Bren at our center. We'll get there quickly. Given our experience from sacituzumab, we know how to handle GCSF.
And I can only say from my own experience, just as you emphasized, you can feel it, you don't feel it. And that's the nice thing about it. You don't feel it, but you can do something about it. And yes, you explained that very, very well. Thank you so much. Then let's move right along.
Now let's move on to something that is practice changing. So again, where you might say, well, maybe that will come at some point, I'll wait and see. Here you have a positive feeling about how things are currently developing. So Iza-Bren is just one of the bispecifics. At our center alone, we have 2 bispecific ADCs in our portfolio, which we can use in certain cases. So there's really a lot happening now. And now for all those who said, well, I'll just see what else is coming. Now, pay attention. For all the patients who are currently taking denosumab, they now have to pay attention. And there we have to compliment Austria. The Austrians helped develop denosumab the most, especially for osteoporosis, early disease, and so on. Now, there is a study where it was looked at. We use XG-EVA when we treat bone metastases, that is every 4 weeks. That was calculated based on pharmacokinetics, and it has held up in this situation, I would say, for over 10 years or longer since we've been doing it. And now our Swiss colleagues have conducted a study and said, well, what if you only give it every 12 weeks? Yes, in the situation in patients with prostate cancer and in female patients with breast cancer. So the question is, if you give it less frequently, is it just as effective? That's the question behind it. So that means they examined over 1,000 patients for this purpose and conducted a so-called non-inferiority study. You always have to do that when you de-escalate something, meaning when you do less, then you have to state whether doing less is just as effective and efficient. That's basically what's behind it. Accordingly, the statistics were calculated. The endpoints are, of course, focused on bone metastases. That means whether skeletal-related events, meaning bone metastases, became progressive again, or the pain associated with that situation. Let's take a look at all of this and whether I administer it every 3 months or once a month. Hazard ratio 1, completely identical. So you can already draw the conclusion yourself. I can administer it every 3 months. That is a very important conclusion in this situation, and that has been shown in all questions, whether it lowers the calcium level in all the cases of jaw osteonecrosis and so on in this situation. And all of that, so to speak, is absolutely certain. That means if I look at this data, for me, starting Monday, or ever since I first knew about this, I have messaged the entire team about this and said, please, all patients, and now comes something important. In the study, there was a loading dose, which means we administered denosumab 4 times, and then it was extended to every 3 months for everyone, so to speak. That means the current standard, which for me applies starting Monday, is that after the 4 times, or for all those who have already had it more than 4 times, they can switch to every 3 months. If you start today, you start with 4 monthly doses and then every 3 months. This is the new standard. So this is the new standard for you if you use eVERA, or if it is being applied. Throughout the entire study, there was no disadvantage in terms of overall survival, side effect profiles, hypercalcemia, and so on. So it is just as effective, and it tends, of course, to have a bit fewer side effects from the already few side effects that we know from eVERA. That means my conclusion is that when treating bone metastases, the administration should not be every 4 weeks as before, but every 12 weeks. Again, it's important to note what I mentioned, the loading phase during the first 4 months should be taken into account.
Thank you very much, dear Sherko. That also changes my life. I also have bone metastases and have been getting injections monthly for 13 years, now only every 12 weeks. That sounds like a really wonderful approach. With all of this knowledge in mind, what specific steps should patients take right now? Should they proactively reach out to their oncology team and talk to them about it?
We both know that this transfer of knowledge always takes time. That's why the advantage is for everyone who takes care of themselves. That's what you're saying. For example, those who watch patients today, who watch this long video with us, who take the time to learn something, those now have the advantage and can, when they are scheduled for their next eVERA injection, as usual, simply call and say, according to the new data, it would only be needed every 3 months. Then, in one or another unit, someone might say, I haven't heard about that yet. This means try to get in touch with your oncologist and tell them, and if everyone then asks, well, what kind of study is it? It's called REDUSE, as in to reduce. That's the REDUSE study, which clearly showed results. And this was also concluded by everyone at the American Cancer Congress. This is the new standard starting Monday.
That's fantastic, and I think it's just sensational that a dose reduction was actually studied. That changes our lives. Super.
It was the Swiss.
The Swiss and the Austrians also helped set it up so that this medication even became available.
I praised that at the beginning.
That sounds wonderful. Long live the entire DACH region. All right, then let's move right along.
So now we come to the next situation. And also what perhaps, that's why there's always a teaser at the beginning, what might be coming your way in the near future. That means you have the CDK, that is hormone receptor positive breast cancer. We already had triple negative and bone metastases. This applies for everyone. And now we have hormone receptor positive, which includes CDK4/6 inhibitors. That's the standard. There's no need for discussion about that. For me, for 96, 97% of all patients, that's the standard. Whether we combine it with aromatase inhibitors or with fulvestrant, or in the small group of patients where at the beginning we have to test for these PI3K mutations, and then, for example, use inavolisib plus CDK4/6 and fulvestrant. So now let's look at what happens when this therapy no longer works. Then there are two major questions in the tumor board. Is chemotherapy necessary now? Yes. Or is the next, what we call endocrine therapy, better in this situation? And most of the time, it's the next endocrine therapy. And when we get to that point, we have to measure certain things in the whole process. Among other things, for example, this ESA1 mutation, the best way to measure this is with a liquid biopsy by taking a blood sample. Once you have tested for this ESR1 mutation and confirmed it develops during the endocrine treatment cascade, if you look at all the cascades, it can be detected in up to 40 to 50% of all patients. Then once you have measured it, you have two options again. You have the approved option, for example, to take elacestrant, which many people know, and SERDU as well, or imlunestrant, which is also approved. Although I think it hasn't really been introduced for many yet, but that's beside the point. We can stick with elacestrant. And now there was a study that said, I'll combine something, I take a SERD, something like what we already know from elacestrant, but here it's called giredestrant. But what is a SERD? A SERD is a selective estrogen receptor degrader. Now, everyone says, well, now I'm not any wiser either. That means it blocks the estrogen receptor so completely that it can't be active anymore. independently of estrogen deprivation or anything like that. It blocks it in such a way that it is then degraded. With the ESA1 mutation, exactly the opposite happens. The aromatase inhibitor lowers the estrogen levels, but the receptor has changed so much due to the mutation that it continues to function as an estrogen receptor even without estrogen. Now, with the blockade by the SERTs, it can no longer do that because it is then degraded. So the SERTs are effective. What was investigated here? Jovidestrant, SARTs plus everolimus, which we know as Afinitor. Please always keep in mind, as I said, I am an advocate of good management because I always say, if you can control the side effects, then you can also administer the medication well in the whole process. That's why with Afinitor, we love to gradually increase the dose. 5, 7, 5 up to 10 milligrams. So in this whole situation, everolimus, we've known it for a long time. We know how to handle it, prophylactic mouthwash. Always remember that. That's why I always give you a few tips on how you can do this as well. So the study tested everolimus giredestrant or everolimus with what we use, exemestane or fulvestrant. That is the classic anti-hormone therapy. That is, so to speak, the standard of care. And the SERT, meaning the new anti-hormone therapy, which is coming and was compared to it. Primary endpoints, again, were progression-free survival, etc. By now, you are already familiar with this in this situation. Now, here the PFS2 was shown. As I said, the Congress was triggered. The question is, does this success that we initially saw also continue in the subsequent lines of treatment? We can summarize, yes, 13 versus 19 months. Hazard ratio, again, clearly below 1. In summary, yes. If we look at the curves again here, so with the approval, this will become a new standard. That means if I make the decision after CDK4/6, I have an ESR1 mutation, meaning I test for it and I have it, then I have to decide, do I go for a monotherapy, for example, elacestrant monotherapy only, or do I go for a combination in the whole approach? That is essentially the decision. Here, the curves for this, and you can see it is effective everywhere, so to speak. That means in terms of safety, we know how to handle everolimus, slowly titrate the dose, and provide prophylaxis regarding the stomatitis, the inflammation of the oral mucosa in this situation. The SERTs themselves, as side effects, often have a very, very low potential for adverse effects. We know that by now. So my summary of all this is, when detecting an ESR1 mutation after progression under CDK4/6 inhibitors, in addition to the possibility of monotherapy, the combination of giredestrant and everolimus after approval is also possible. And that will happen because the study is so positive. Thank you.
Thank you very much. Dear Sherko, I have a quick question for clarification. I just read about improvements both in the ESR1 positive group and in the ESR1 non-detected group. Does that mean that giredestrant and everolimus could also work in the absence of an ESR1 mutation? Think this could work?
Claudia, now I have to pay you a compliment. That's something that not every colleague can quite... I can give you the exact data because we have dealt with this very intensively, also internationally. So we see when we measure ESR1 mutations at PFS1, the important part, there is a hazard ratio of 0.4 using the substance, which is a 60% improvement. If I don't have the ESR1 mutation, the hazard ratio is 0.84. That means a 16% improvement. Of course, when I lump everything together in the overall population, the result was positive overall, but you have to say that the effect was really driven by the patients who had the mutation. So I truly believe if you perform a test for the mutation, then that's the patient who will most likely benefit from the combination.
I see. That is very good. And then we have one last study for us to look at. And it has been a pleasure up to this point, and I have to say, you are turning us into hobby doctors. Really, we are gaining so much knowledge and so many explanations. That really makes us empowered, well-informed patients. Thank you very much at this point.
Absolutely, because this is part of my daily routine in the clinic as well, because it's no use if I just rattle it off in 3 minutes, like in a lecture, and the patient doesn't actually take anything away from it. Because in the end, the information is for her, not for me, in all of this. And now we come to the question, so let's sharpen our focus again. Something really exciting is coming your way. For this next issue, the FDA, the American Regulatory Authority, which I would say is usually the first to approve something when there is positive data, has said here, we're not quite sure, we're still being cautious. In all of this, the European Regulatory Authority, which usually I would say, grants approval with a delay of about 8 to 12 months. For the strategies we've just discussed over the last half hour, has already said here, this should be done in this situation, so stay alert. Stay altered. This could become available to us in Europe in the near future. So what was actually done here? Earlier, we looked at the CDK4/6 complex, and if I then detect a radiological progression, that is, I have more metastases or growth, then I'm in the second line of treatment. If I then measure the ESA1 mutation, I use giredestrant everolimus. Now let's go a step further and say, if I am undergoing therapy with CDK4/6 and aromatase inhibitors, letrozole, anastrozole, ribociclib, abemaciclib, palbociclib, and I then measure every few months whether an ESR1 mutation occurs, and if the ESR1 mutation does occur, these are the blood draws, then I switch to a therapy now called camizestrant. Now you are already knowledgeable enough to say that elacestrant is a SERT, giredestrant is a SERT, camizestrant, so all the astrands are SERTs. Yes, that's basically the commonality. Camizestrant, the next SERT, is particularly effective as the first one, as I explained to you a bit earlier with the receptor. So, and now it goes like this. I measure with the liquid biopsy, and if I have the ESA1 mutation, then the question arises, do I switch? So do I change the therapy or continue? Radiologically, there's no metastatic progression, no growth or new lesions. I've only seen in the blood that a mutation has formed, as ESR1 is an acquired mutation. Looking at this, they then have examined, should I stay on therapy since I haven't seen any radiological progression yet, or do I change the medication based on the information from the blood? What happened there? As always, endpoints like PFS, progression-free survival, and now, as is often the case at ASCO, the PFS2 was also shown in the overall situation. And if I do that, you can see from the initial analysis, 9 versus 16 months in the whole thing. And this continues in PFS2 in the overall situation. So here again are the curves. If I perform this measurement early on during therapy, then it is, so to speak, beneficial for the patient if I switch therapy. Overall survival isn't clear yet, which is why the regulatory authorities are still cautious. And importantly, we can answer the question whether waiting until radiological progression to use elacestrant or giredestrant with everolimus will be just as successful. We simply don't know that. It's even possible. That means some things are still not quite clear. These are great data. It's the next step we should be thinking about, but it's certainly not for every patient. So where else might we find ourselves encountering such a gap? While undergoing treatment with CDK4/6 inhibitor, I can request that my health insurance provider covers a liquid biopsy if I don't have progression as a monitoring test to see whether I have an ESR1 mutation. I think I still have to reapply for this with the health insurance today because in the code enabling a liquid biopsy, this isn't specified yet. Again, during therapy with a CDK4/6 inhibitor, plus an aromatase inhibitor, you can, after insurance approval, do a serial blood test, liquid biopsy every 3 months for a developing ESR1 mutation. This allows for a switch to camizestrant as soon as the mutation is detected. And we will probably have this medication available for this indication at the end of the summer break. Thank you very much.
Thank you very much indeed, dear Sherko. I have one additional question about the ESR1 status. How often does it generally make sense to have it evaluated and tested, and which is better, a tissue or a liquid biopsy?
That's the right question. If we look at it, so first of all, whether I find it in the tissue or in a liquid biopsy, the effectiveness is the same. Where do I detect it better? So where is the sensitivity higher for me to discover it? In the blood? So that means you should look for it in the blood. That means liquid biopsy. It's more pleasant for all of us anyway. Drawing blood is always better than having to perform a biopsy in that situation. So liquid biopsy in this whole context. And the question is, when do I measure it? Well, we always do it. I always measure it whenever I think that a therapy with a SERT might make sense. Then I measure it. That's the simplest way to put it. If I think I need chemotherapy or something else, then theoretically I do not need to measure the ESR1 status either. But I would say for all patients after CDK4/6, it is standard practice for us. In studies, we often measure it already at the onset of the disease, but that's very important, and that's another very important point. If you ever had it measured and it was negative, which is often the case, then say, no, it's not always negative, because this is one which is, for example, in the early stage of the disease. Early breast cancer, it's only present in about 2% of patients because it is an acquired mutation. Over the course of the disease, it increases to 40 to 50%. That means you have to keep checking it in such cases. If you want to use a SERT, because it doesn't mean that just because it was negative 6 months ago, well, then it's negative. No, it could have turned positive by then. And I think that's a very important insight.
Absolutely. Thank you so much for your excellent explanations. And yes, even though metastasis is a significant and overwhelming burden, these new findings certainly seem to offer much more. Longer life and even better quality of life, and we need both, and we are happy about research and development, of course, because we patients benefit enormously from it. Dear Sherko, I thank you very much for your clear and comprehensible explanations. Your incredibly thoughtful remarks give us renewed courage and hope, and that is exactly what we need most right now. With that, we have reached the end of our ASCO coverage. Thank you, dear hosts from patients today, and thank you all for being with us. Until next time.